And the next speaker is Dr. Prashant Puranik. He is a reconstructive surgeon currently working at HCG, Bengaluru.
At the outside, I would like to thank the entire HCG team, Ahmedabad, for giving this opportunity to present. That was an excellent talk, one side of the coin. Let's look at the other side of the coin. The visceral tubes for circumferential pharyngeal defect. The key deciding factor is the lower cervical esophageal cut, whether it is below the or above the thoracic inlet. Below the inlet, it would be a gastric pull-up. Above the inlet, it would be free flaps like faciocutaneous or a jejunal flap. Gastric pull-up is still commonly done because of synchronous esophageal disease or no facilities for reconstruction. But it has a lot of disadvantages like high intrathoracic complications, gastric dysfunction, and tension and anastomosis, which can lead to partial or total necrosis of the distal tube, which may require flaps like tube PMMC flap with an additional skin graft or a local flap for the external skin cover. Other options could be flaps like tube supraclavicular flap for these complications, which can also require a skin graft or a bipedal supraclavicular flap for external skin defect. Preventing these complications may be more crucial. We can try to do supercharge of these proximal stomach vessels to the surrounding vessels. Usually these vessels are of size less than 1 millimeter. Patients who have gastrostomy, which is a relative contraindication, or in patients who require primarily a free flap, can be managed with jejunum as a first line of treatment. Jejunum has been one of the first flaps used for circumferential pharyngeal defects. It's placed on the second or third branch of the superior mesenteric artery. The flap harvest begins with supraclavicular incision, identification of the ligament of the treats. About 30 centimeter distally, a segment of the jejunum is chosen. Proximal end is marked with a suture and the mesenteric sleeves are opened up. Good control of the vascular arcade is very essential to prevent any intra-abdominal hemorrhage. Subsequently, the pedicle is dissected, the vessels are dissected to the source. The pedicle is a branch of the superior mesenteric artery. Good dissection of this pedicle is very crucial. Similarly, the dissection is done on the lower aspect of the mesentery, and pedicles are ready to the point they are ready for the entire anastomosis, even adventitiectomy. After this, the bowel is divided proximally and distally using GIA stapler. The proximal part of this jejunum can be used as a conduit for pharyngeal reconstruction and distal paddle as a monitoring paddle. Good dissection of the pedicle to the point they being ready for anastomosis is very crucial to reduce the ischemia time, as jejunum has a smaller ischemia time compared to faciocutaneous flaps. Similarly, the head end is analyzed, vessels are prepared to the point they are ready for anastomosis. After this, the jejunum is divided and taken to the neck. Proximal enterotomy is done to match to the dimensions of the upper anastomosis, and it is very easy to match the dimensions compared to faciocutaneous flap. 2 anchoring sutures are taken and the quick anastomosis is done. Here we do it in less than 30 minutes, usually 20 minutes. Good peristalsis indicates a well-perfused flap. After this, the posterior and anterior wall of the upper anastomosis is completed. Planning for the lower cut is planned. Very crucial that we keep the jejunum taut and not very redundant. The lower part is divided again with a staple, and enterotomy is done to match the cervical esophagus, which is difficult with a faciocutaneous flap. Using parachuting sutures for the posterior wall makes the posterior inset a lot more easier and more reliably watertight. Fricas tube is passed. After this, the anterior wall and anastomosis is completed. That's the taut jejunal flap with a monitoring paddle. Jejunal continuity is reconstructed with end-to-end or end-to-side anastomosis. These patients have a good swallow rehabilitation. By about 2 to 3 weeks, they are able to be back on full oral feeds. Other visceral flap is ileocolonic transfer, which can restore the voice also. This is based on distal branches of the superior mesenteric artery. The harvest is done with the help of a GI team. Here, the ascending colon acts as a pharyngeal conduit, and distal end of the ileum or appendix can be used for voice restoration. Checking the competency of the ileocecal wall is very crucial for the success of the surgery, and pedicle dissection is done. Competency of ileocecal wall is again confirmed with retrograde flush and no appearance of the dye in the jejunum. The defect is analyzed and parachute sutures are readied so that the ischemia time can again be reduced. This is a nasopharyngeal oropharyngeal defect which was quite wider. Ascending pharynx was probably the best option compared to any flap, and the anastomosis was done quickly. Following the anastomosis, the upper end insert is done, posterior wall first and the anterior wall. Cecum is used for distal anastomosis and it can match the dimensions of cervical esophagus. Posterior parachute sutures followed by Freckas tube insertion followed by an anterior wall insert. Jejunum is ileum is divided into two parts. One part goes around the stoma for voice restoration, other one is used for monitoring paddle. Mesenteric chimeras can be used both in jejunum and ileocolonic flap, which can buttress the super and inferior suture line so that the fistula rates can be significantly reduced, and the second team completes the ileocolic anastomosis. The speech rehabilitation is done by blocking the tracheostoma. Once it's blocked, the air enters into the ascending ileum through there into the cecum, which can help in voice restoration. So other option could be use of appendix for the speech rehabilitation. So swallow rehabilitation is much quicker. These patients are back to the regular feeds. This has a video. He's an Arabic patient with very limited number of English words he could speak. I just hope this plays on. The voice restoration would take some time. Initially, they find it difficult to speak. They are taught some blowing exercises so that the air holding capacity in the cecum can be increased. So this will be esophageal speech. That's all he could speak. And the visceral tubes are most physiological because they are similar tissues like alimentary tract with a very good diameter match and mucosal surface for lubrication. They are non-hairy compared to fasciocutaneous flap and not bulky, so the neck reconstruction is also easier. And here the approximation is for mucosa to mucosa rather than discontinuous structures like mucosa to skin. Short ischemia time can be managed with good planning. Laparotomy can be replaced with laparoscopy. Fragility of veins, of course, might require some higher skill, and flaps can be neovascularized with some technical modifications. It's contraindicated with ascites, extensive abdominal surgery, or previous intestinal diseases. Coming to the debate, the parameters that have been analyzed are quality of life parameters like speech, oral alimentation, or complications like fistulas, stenosis, or stricture. The concept of early 2000s was that fasciocutaneous flaps are better and might become the first choice. Down south, we have a lot of articles which are in favor of fasciocutaneous flap and also in favor of jejunum. There were some early studies in 2000s which said fasciocutaneous flap can probably be the first choice. Come down in these recent times, a lot of meta-analysis and systemic reviews have pointed towards jejunum being a free flap. This article from 2019 with 1,200 patients said that jejunum should be probably the first excellent choice because the fistula and stricture rates are significantly lesser with jejunum, though other parameters may be quite similar. This was one of study of 2021, which 15 years of series evaluated. This said ALT may be better with lots of other captions, but if you just analyze the sample size, the number of jejunums that are done over the last 15 years is 5 times the number of ALT flaps that are done over the last 15 years. Similar kind of findings being reported, saying that ALT flaps or fasciocutaneous flap, they have higher complications like fistula, stricture. With respect to speech and swallow, jejunum may be better. To conclude, visceral flaps have various options like gastric, jejunum, ileocolon, or colonic transfer. They are best tissue because they are more physiological, like with like tissue, alimentary tract with alimentary tract, which can provide a better lumen match, expandability. In some cases, we can have a speech rehab without need for processes and its associated complications. Good oral alimentation with visceral flaps has been known since decades. It's now shown that similar speech results are present. Donor site morbidity can be minimized. Higher number of jejunums performed over years suggests the popularity of these flaps compared to fasciocutaneous flap. In this pharyngeal reconstruction, all these flaps are still essential and will be in vogue, but at the heart of this puzzle will lie the visceral flaps like jejunum, gastric pull-up, or ileocolonic transfer. Thank you.